Hi, I'm Dr. Jared Gardner. I'm here today with my awesome Dermpath Fellows. We're going to do some random unknown cases. They have not had these slides available to preview. I'm just pulling them straight from my study set right now. So, now this one, as you can tell, is an old slide. It's been beaten up a bit in my slide box, so unfortunately the cover slip's scratched, but let's see if we can still do something with it. Any idea where on the body this might have come from? No skin on it, right? But we're near skin, right? Because we got eccrine coils. Another hint right here. The Pacinian corpuscle. So we're on acral skin, right? Usually if you see a chunk of soft tissue that doesn't have any epidermis attached, and it's really frayed and ragged at the edges, and you see little eccrine coils at the edges, and ideally you'll see some tendon sheath, which we don't have here. But if you did, those things all make you think of hands or feet because they kind of pluck out, the surgeon kind of plucks out the tissue and it kind of pulls, I feel like this is how it happens, because they're trying to, be careful to not take too much tissue, rightly so. So we got a spindle cell lesion here. Let's see if we can get, the other side's a little clearer. Okay. What kind of pattern is this? Kind of almost sending these little fingers of tumor out in between the background soft tissue, the fat, and the dense connective tissue here. And we've got areas like this. Round, kind of histiocytoid cells in a little nodules. See how it's this little micro nodule kind of, or nest almost? Here's more. Here's one. Here's one. Here's one over here. There's another couple in here. So they're kind of like histiocytes arranged into these little nodular aggregates. Sometimes you'll see giant cells in those aggregates. Let me see if I can find. Like so. So there's a giant cell right there. And if you're watching this at home, I'll try to eventually get these slides scanned. They're glass slides I'm using today, but I'll try to get them scanned and post it online. So if you're watching this in the future, check down in the video description and see if I've added links yet. It may take me a little while to do it, but eventually I'll try to get it done. All right. And then, in addition to these nodules of histiocytoid cells and giant cells, we have a second kind of pattern in between. What kind of arrangement do we have here? What would you say about that? So in between these little nodules, we have spindle cells that are more elongated. See, like right here, you can see that here's the nodule of rounded histiocytoid cells, and then the cells become more spindled and kind of fibroblastic looking, and they run in elongated fascicles. So the combination of these two patterns together with the low power appearance that's kind of plexiform. So I'll tell you that probably you've never seen one of these before because they're quite rare. I've only seen a couple in my whole career in training. So the combination, though, of spindle cells that look kind of fibroblastic arranged in fascicles with these nodular aggregates of histiocytoid cells with giant cells, that is good for plexiform fibrohistiocytic tumor. Plexiform fibrohistiocytic tumor. And you can see it does have a plexiform arrangement here. And it does have those little nodules. And then it has fascicles of bland fibroblastic spindle cells. So these are kind of an unusual soft tissue tumor. I guess all soft tissue tumors are probably unusual to most people. And these are relatively rare, or well, really quite rare in my experience. But they can arise in the soft tissue, and I think this one was from the distal extremity, like I said, the hand. I think it was of a child, if I recall. And they usually are indolent, but there have been rare cases that have, I think, metastasized. So they're currently considered, I think, in kind of that intermediate malignant potential category. Actually, let me pull up my WHO book here and see. I haven't looked at this for a while. See if there's some new information here that I should be telling you. I probably should have looked that up ahead of time, but here we are. So we'll look here in the WHO 5th edition, which is an awesome book, and it says that these are predilection for the upper limbs and then the lower limbs, but also can be on the trunk or head and neck, and that they are a wide age range, but it's more often in kids and young adults. Median age is between 14 and 20 years. They're usually small, and they're often around the dermal to subcutaneous junction, like we saw here, right? The eccrine coils here, we know we're near the dermal subcutaneous junction. I'll have to try to get this slide recover slipped, although I'm a little scared because if you do that, sometimes it messes the slide up. And this is like this is the best example I think I have of this. And that they have a risk for local recurrence between 12 and 37%, and rare lymph node metastases, but there have been distant mets to the lung has been reported, but it's exceptionally rare. It looks like they have referenced only 2 papers here, so for distant mets. So basically, these usually are indolent, but there are super rare exceptions to that rule. So I guess if you think about it, dermatofibromas have rarely metastasized too. So but they're so common and that happens so rarely that we still consider them to be benign. So one thing to keep in mind though in the differential here is when you see these histiocytoid kind of plump cells arranged in little nodules or nest-like aggregates, another tumor that does that is cellular neurothelioma, and some people have even proposed that there may be a relationship between these two because they neither of them have really specific staining characteristics, and they both have these kind of histiocytoid cells that are arranged in aggregates. And despite the name, cellular neurothelioma is of course not a nerve sheath tumor, even though it's a misnomer. It sounds like it, but I have a whole video actually about cellular neurothelioma and nerve sheath myxoma, which have been very confusing nomenclature-wise in the literature, so you can go check that out if you're watching this at home, and it'll explain in more detail. So a rare bird here, Plexiform fibrohistiocytic tumor. It's got a lot of vascular channels, and if you go in and look at it like here, it looks very busy and very complex. A lot of kind of interconnected spaces that all anastomose with one another. But when you look out at the periphery, it's actually really well circumscribed into several nodules, right, or lobules that have a very smooth border. So in the middle, it looks very infiltrative and busy, but at the edges, not so much. Actually, not at all. Here's another view over here. So we can't see the whole lesion, but from what we can see of it, it's really respecting the adjacent tissue. And in some of the spaces, there are fibrin thrombi. Bright red, you can see there. And the endothelial cells are bland, although you have some little ones that hobnail or protrude into the lumen, but they're small and they don't have much atypia. Occasionally you'll see little scattered larger ones, it looks like. the endothelial cells, usually angiosarcomas are going to have really ugly tumor cells. There are rare exceptions of kind of well-differentiated angiosarcomas. And Kaposi, which is not super ugly, but still they have some atypia. These are really bland, and hobnailing or protruding into the lumen, while malignant things, vascular tumors can do that, so can benign things. So lots of vascular lesions have hobnailing of the cells. And the fibrin thrombi here are interesting. So one thought you could have is, could this be a so-called Masson tumor or papillary endothelial hyperplasia? But I think that most of these areas are actually vascular spaces that are really formed by having collagen around the wall of the vessels, and are not actually just organized thrombus. There are some organizing thrombi here and there, but I think that this lesion, actually most of these vascular channels are part of the neoplasm here, rather than reactive endothelial cells organizing a thrombus. So this is what I think, this probably fits into the category of what's been called anastomosing hemangioma. And these were first described in the genitourinary tract, but they can occur in a variety of sites, and I've seen a couple of them now, I think, near the skin or soft tissue, more superficial soft tissues. So they're good to know about, because normally when we talk about hemangiomas, we say that they're, kind of more lobular or nodular and not infiltrative, and that they have well-formed vascular spaces, not interconnecting anastomotic ones. Usually when we see interconnected vascular channels, we get worried about the possibility of angiosarcoma, right? One of the things about angiosarcoma is that it infiltrates the tissue and has these interconnected anastomotic spaces. Well, that's exactly what we have here, but it's kind of a trick. It looks anastomotic in the middle of the lesion, but then when you go out to the periphery, you see that it's actually not infiltrative at all. It's just very busy and interconnected in the middle of each of the tumor nodules, but out at the edge, it's actually very circumscribed. In a way, it's a little analogous, to make a Dermpath analogy, a little analogous to like how you can see, desmoplastic trichomoniasis. In the middle, very busy, looks like an infiltrative tumor, like an infiltrative basal cell, but at the periphery, very smooth, nice borders. So I think that's kind of the same sort of thing that's going on here, that in the middle it looks kind of concerning, but at the edges it's not. So it's good to know about, because it's a relatively newer entity. It's not been around for a long time. And sometimes also they can get little eosinophilic kind of hyalinized droplet inclusions in the cytoplasm. You can see extramedullary hematopoiesis with them, I believe. They have actually a gene abnormality, which is relevant and interesting from a Dermpath perspective, because it's the same gene abnormality that's been described in blue nevi. So why on earth? Who knows? But what is that abnormality?
GNAC or GNA11.
Yeah, GNAC or GNA11. Good. This one actually has GNAC or GNA14 has been described. Blue nevi both have GNAC, GNA11. Here in anastomosing hemangioma, GNAC and GNA14. So that's what we want, anastomotic vessels with hobnail and endothelium, and then you can sometimes have hyaline globules and extramedullary hematopoiesis, and one or two of the ones I've seen before also had some thrombi in them, like this one does. So good thing to know about, because it looks a lot scarier than it is. Kind of a nodular tumor here in the subcutis, it looks like. Let's say it was on the leg of a 80-year-old man. I don't actually remember the exact history on this one, but they thought it was a cyst clinically, because, it's always a cyst until it's not a cyst. It's a little harder here because it's an older slide, and so pretend this is a light blue color. Okay. This is myxoid or mucin, okay? It looks kind of like white now, part of that being the projection onto the screen, and also part of that being that mucin or myxoid tends to really quickly fade out on H&E slides. I feel like even after a few years, the bluishness of them goes away. So low power, you might think about like a myxoma if you can tell that it's blue and myxoid. Pretty hypocellular, right? But then when we go in closer, so in this case, the ugly pleomorphic cells in a myxoid background are going to make me think of Myxofibrosarcoma. So this would be an example of like a grade 1 or a low grade Myxofibrosarcoma, where you just have pleomorphic ugly cells, but it's very hypocellular, and they're scattered in this myxoid background. And let me see if I can find another one. Okay, here's more over here. So ugly, but very, very sparse and rare. Look at that. You also, with these, tend to have elongated, kind of curvy linear vessels is what people call them. Let me see if I can find a good area here with one. You don't always see them, but they kind of usually develop this prominent, there we go. See how it's elongated vessel? You're seeing it kind of cut in a, one here, and then this is the same vessel, just kind of it's kind of curving gently as it runs elongated. So you often have these elongated, kind of slightly curving vessels, and then myxoid change, and then ugly spindle cells. And when they're very hypocellular like this, we say it's grade 1. Once they start getting cellular areas clumping around the vessels, then usually I'll call it grade 2. When it has sheet-like areas that look like undifferentiated pleomorphic sarcoma, like a high-grade sarcoma, then I call it grade 3. Somewhat subjective grading, but that's kind of the way we do it. And then the thing about myxofibrosarcomas is they tend to infiltrate into the subcutis. They usually arise, half of the time they arise above the fascia, so that means in the subcutis or even in the dermis. So it's a really important sarcoma for dermatopathologists to know about, because they often show up in the skin, and I've seen them multiple times biopsied as rule-out cyst, and someone thought it was a cyst clinically, and they plucked it out, and it ended up being a myxofibrosarcoma. As sarcomas go, these are relatively common. I mean, all sarcomas are rare, but, some sarcomas I see once a year or once every few years. Myxofibrosarcoma I see, multiple examples of every month, I would say, in general. So I encounter them frequently. But see here, I got the edge of this nodule, the tumor cells and the mucinous background or myxoid background are oozing out here. They're traveling along the septal spaces in between the subcutaneous fat lobules. They can travel along the fascia in the same way. Sometimes they do arise in the deep soft tissue, like the deep skeletal muscle, and they can ooze in between muscle fibers. So because of this, the real infiltrative growth, they often are really difficult to get around and clear surgically. They have to go way farther around the tumor than you would usually have to do. So a lot of sarcomas, right, are smooth and circumscribed borders. They grow quickly, push the other tissue out of the way, but there are some that are infiltrative, and this is one of them. Myxofibrosarcomas tend to be very infiltrative and sometimes very sneaky and subtle in their infiltration. And so when you're looking at something, you're thinking about a myxoma in the skin, the main thing you want to do is look for ugly pleomorphic cells, and then when you see those in a myxoid background, you start thinking about myxofibrosarcoma. So you must have some atypia to make this diagnosis, to be able to recognize it. I mean, you have to see at least some pleomorphism to call it a myxofibrosarcoma, grade 1. When they're in the superficial tissue and they're grade 1, they almost never metastasize, but they can recur, and when they recur, sometimes they become higher and higher grade with multiple recurrences, so they can eventually kind of turn into higher grade and then be problematic. So good thing to be on the lookout for, and they are usually in the extremities of elderly adults, and again, often superficial in the skin or subcutis. This is a really good one because it's very, very subtle. Like, I mean, from low power, you don't look at this and think of sarcoma, right? And yes, the other thing to remember is that not as much in skin, but that you can have you can have Myxofibrosarcoma-like areas that look kind of like this. In other types of sarcoma, particularly liposarcomas, can get very myxoid. I see that a lot of different times where you have areas that look like Myxofibrosarcoma, but then you find lipoblast, and so it's like a pleomorphic liposarc, or a D-diff liposarc also can have Myxofibrosarcoma-like areas. Not so much, not often to see D-diff liposarc in the skin. Occasionally you'll see pleomorphic liposarcoma there, but usually they're going to be much more cellular and much more abundant atypia than this. Let me see if I can find another. Here's some skeletal muscle down here. Whoops. Can't go any lower. I'm used to teaching with digital slides and where I can go super low power, but here this is as low as I can get. So this is more obviously myxoid in blue, right? Look at these vessels. Elongated curvilinear vessels. This is hypocellular, but not nearly as hypocellular as the last case. The last case is the extreme low end of cellularity for Myxofibrosarcoma. This is more cellular, and when we go look closer, some of the cells look bland, but if you start looking around, you'll find pleomorphic cells in there. And the cells kind of are clustered near the edges of these vessels. You'll often see them kind of starting to get more cellular. See how they're aggregating around. Here's the vessel right here. And the cells are lining up or clumping up around it, okay? Like this. So in this, I would probably call this a grade 2, and I think there were even worse areas. Yeah, there we go. See there how it's starting to get more cellular? And definitely ugly atypical cells now. And then this case went down past the fascia and into the muscle. And also, interestingly, there's a ton of inflammation here. I'm not sure why in this case, but there, look, it's starting to get really ugly. And though this is a really good example, though, of how this tumor grows. Look at how infiltrative. All the stuff here, that's all skeletal muscle, and all in between it, Myxofibrosarcoma. Oozing between. Look at that. All the way out to the margins, usually. So I know the sarcoma surgeons I've worked with really, they find these tumors very difficult and frustrating because they really want to clear them, but it's very difficult, and they'll have to go way out around the tumor sometimes to get clearance. And then over here, look, here looks like we're in background, normal tissue. We got big vessels and adipose tissue here. But look what we find. Ugly cells that have infiltrated out here. It's like the mucin gives them, or the myxoid gives them the ability somehow to ooze out. Now in this setting too, you could also think, if you just saw these areas, you could think there's fat tissue and ugly cells in it. What about well-diff liposarcoma or atypical lipomatous tumor? And certainly if you thought about that, you could do MDM2 to sort that out. Because it's true, you could have a well-diff liposarc that becomes dedifferentiated and becomes myxoid. But also, Myxofibrosarcoma infiltrates into fatty tissue and can mimic the appearance of well-differentiated liposarcoma. So it can become difficult to sort out. But here, very ugly cells in here. So this case shows the infiltrative growth of Myxofibrosarcoma. Very dramatic here, splaying apart the skeletal muscle bundles. It also highlights the heterogeneity that you can see in myxoid tumors, but particularly Myxofibrosarcoma. Look at how different this area looks as far as cellularity goes. And then you've got areas like this. It really can run a range. So that's why a smaller partial biopsy of these can be really difficult, because these often have very, very different appearing areas in the same tumor. And then the last thing I'm going to show you here before we go to the next case. There it is. That cell let's try to get the light right. So it is a little hard on projecting myxoid tumors is hard because the light, the camera wants to white balance it, and so it sometimes washes the blue out. But you can hopefully see that in the center of this ugly cell has vacuoles in it. But the vacuoles, instead of being white and clear like you would expect for a lipoblast, they're blue actually. They're filled with blue gooey mucin, myxoid material, whichever name. I keep going back and forth because I know in Dermpath, a lot of derm trained people use mucin, and in soft tissue, we say the word myxoid for this blue stuff. But in any case, here's another one here. So these cells are tumor cells that have sucked up that blue myxoid gooey substance from the background and made vacuoles, and they imitate the appearance of pleomorphic lipoblasts, but they're not really lipoblasts. These are called pseudolipoblasts, and they are important to know about because A, you don't want to see them and mistake them for lipoblast and call something a liposarcoma. And B, because they're actually a helpful diagnostic clue. When you see these, it can be seen in some other things, but the main setting you see them in is Myxofibrosarcoma, and another tumor that can look a lot like Myxofibrosarcoma, which I know you're going to hate the name. It's called myxoinflammatory fibroblastic sarcoma. It's the one that has those huge giant nucleoli that look like Reed-Sternberg cells, or like viral infected like CMV cells. And they tend to occur on acral surfaces and have tons of inflammation. So yeah, you could actually think of that here, but this one's so myxoid that I think it fits better with a myxofibrosarcoma. So that's a good example here. And I'd probably call this one grade 2. Obviously there was more sections here. I don't remember what it finally was, but in these areas here, I'd say this probably is a grade 2. It's got some cellular zones of really atypical stuff, but it doesn't have sheets of high-grade sarcoma. So, all right. I guess while we're doing that, I should probably show you. This I would call grade 3. I mean, areas like this look like any other high-grade sarcoma. Big, ugly mitoses, solid sheets of ugly tumor cells, bizarre atypia. It's a pretty old slide, so it's unfortunately very faded. But these areas, they used to be blue. So see, that's how we got high-grade sarcoma. Sorry, I can't get the light right. High-grade sarcoma, and then areas here that had loose myxoid stuff with elongated vessels. So that's Myxofibrosarcoma, grade 3. I wonder if I have a better one here. No, it's from that same case. I guess the myxoid stands out a little bit better on this slide. Okay. Cannot get the white balance quite right on this though. There, that's good, I guess. What are we going to do with this? So busy, right? So if you look at this right up close, it may be very confusing. It's very cellular, lots of stuff going on, lots of hemosiderin and blood in here. Let's go back to low power and look at it again. Now,
Dermatofibroma.
Very good. Yes, dermatofibroma. So the lesson here, as usual, is we start at low power, right? Because these tumors, the low power clue for dermatofibroma, those are the things that are going to help you see in the epidermal hyperplasia over top with some blunting or tabling, flattening of the reedy ridges. You know, the lower and deeper down a DF is, the further away it is from the epidermis, the less of that epidermal hyperplasia you tend to see, I've noticed. And then you've got nice collagen trapping at the edges. Look at that, collagen trapping at the periphery, very nice. And then in the midst of it, it gets busy and crazy, and this is where people tend to get really worried. They start looking around in here, and they see all these big plump cells in sheets, and they see blood and open spaces, and they start thinking about a malignant vascular thing or something, or something else. People start getting really worried. But in fact, this is the normal kind of cytologic features of this type of DF, which is either an aneurysmal or hemosiderotic dermatofibroma, kind of like overlapping features. But they tend to get big blood-filled spaces and abundant hemosiderin, foam cells, multinucleated giant cells like Teuton cells. And this one's a good example, too, of a phenomenon you can see from time to time. That's a really good, actually, example. Oh, yeah, here's the blood-filled spaces. But look right here. These cells look kind of different, don't they? Right here and here. So these are Langerhans cells. And see, you can even see the grooves in them a little bit, right? See right there? So I've seen this before from time to time, that DFs can sometimes get, especially when they have a lot of blood in them, you can get ones that really get aggregates and pockets filled with Langerhans cells. So guess what happens if you do an S100 here? You see all sorts of staining, very, very busy, and the cellular pockets. And if you know about this trick, then it's easy. If you happen to, I think on this you don't really need to do stains once you know that this is the features of a aneurysmal or hemosiderotic DF. It's usually an H&E diagnosis to me. So, but if you weren't sure and you did stains, the S100 could really lead you astray. Of course, if you do a SOX10, it'll all be dead negative. So that's a way to easily solve that problem. But I've seen, people get mistaken about that and overcall things as melanoma and other stuff because of when there's really robust background Langerhans cell infiltrate. So just know that you can sometimes get abundant Langerhans cells making these kind of aggregates or pools in the background of a dermatofibroma, particularly these hemosiderin-rich aneurysmal ones. And you could also make the argument, if you wanted to call this a cellular DF, you could. I usually call things cellular DF when they have like intersecting fascicles of more spindled cells. But clearly this is hypercellular, and I do think that the aneurysmal dermatofibromas exist kind of on a spectrum with cellular dermatofibromas. They tend to be bigger, go deeper into the skin. If you only get a partial biopsy, they'll continue to grow, and sometimes can actually truly recur. But they persist or recur more often than regular DFs. And you can, of course, see mitoses and scattered pleomorphism in dermatofibromas, and that is nothing to worry about. Good collagen trapping there, too. So you guys nailed it. Oh, there's more collagen trapping. Nice. This is the kind of pattern that I usually will call a cellular DF. See, they're kind of these fascicles there. They're all streaming together as fascicles and intersecting with one another. But this one is a little tricky because look, it's totally down in the subcutis. So dermatofibromas, which soft tissue pathologists sometimes call benign fibrous histiocytomas, they don't always occur in the dermis, usually, but you can sometimes see them in the subcutis, either extending into or fully centered in the subcutis, like we see here, or even in the deep soft tissue. I rarely ever seen that, but it is reported that they can happen like in the muscle. I'd be very hesitant about that, but it is reported. So, and here we've got some scattered pleomorphism. In this case, it's like actually a giant multinucleated giant cell there, it looks like. But you can have some scattered pleomorphism, mitoses. Cells here are way too plump to be like a dermatofibrosarcoma protuberans, right? Those are usually much more thin, narrow cells. And you can also, of course, do a CD34 if you have any doubt about that. There was a mitosis right there. A couple mitoses. And here I will point out, See the little skeletal muscle strands? I believe this was actually from the face, and from the face of a young adult, and so that skeletal muscle right there was the clue for that, and removed probably as rule out cyst, right? And the reason I want to point this out is that on the face, you don't often get dermatofibromas on the face, but when you do, cellular dermatofibromas are the ones that I see there the most. And they tend to be kind of deeper and more cellular, and they're often in kids or young adults on the face. So it's an important pitfall to know about because it looks kind of different. It's an unusual anatomic site where you're not expecting it, but it's definitely well described, and I've seen this multiple times where they'll present as a deeper subcutaneous nodule of a cellular DF on the face, and again, usually in young adults or kids. Oh, this is a nice one. Wow. You seen anything like this before?
Reminds me of dermatomyofibroma.
Yes, it reminds you because that's exactly what it is. This is a dermatomyofibroma. Very good. And the key here is at lower power, you can see that you have these parallel, like very nice parallel fibroblasts running in parallel to each other, making fascicles, and the fascicles run parallel to the surface. They go across the dermis back and forth like this. And you can really see it here at lower power that they very much have a parallel association with the epidermis. And they're really nicely organized fascicles too. And the spindle cells are very nicely parallel to each other also. And I know you guys know this, but for anyone watching at home, even though these cells are super wavy, they are not nerve, right? Because usually nerve is not this wavy. Things that are really wavy with the collagen bundled up like that, like ramen noodles in the pack, usually are fibroblastic or myofibroblastic. So you can look up on my channel the ramen noodle sign of Fulton in honor of my former fellow Ed Fulton, who came up with that idea. And so even though it's wavy, it's not nerve, okay? These are actually not muscle either, and I don't know exactly where the naming came from, but the dermatomyofibroma, I don't know if it's that people thought this looked like muscle. There's probably a history here, I don't know, but the name is confusing because it makes you think that you should be able to get them to stain with myo markers. You don't need to, in my opinion, you don't need to do any immunostains here. It's an H&E diagnosis to me. If you do immunostains, you'll be a little frustrated because Desmond's basically always going to be negative here, or almost always. Maybe there's some rare exception, but as a general rule, negative for Desmond. And actin, smooth muscle actin, only stains these about 50% of the time, which is like, so just flip a coin instead of doing that immunostain. Because if it's negative, you're going to say, well, is that okay? Yes, it's okay. It's well understood that they are fibroblastic basically, and they sometimes will have some myofibroblastic staining, but a lot of times they don't. So about half the time they'll be negative for actin, and they should usually be negative for Desmond. So don't need to do any stains here, and they're benign and just a pretty thing to look at. The other thing that can look kind of like this, oh yeah, the other thing is, look at this too. The normal dermal structures are all preserved, right? This tumor is like kind of just like hanging out in between all of the dermal stuff, the eccrine ducts and eccrine coils, the hair follicle. None of it seems, the rector pili muscle, none of it seems very disturbed by the presence of this dermatomyofibroma, right? It's just kind of grown in between all of it and not causing any problems. But if you see a similar pattern to this that's maybe not quite as parallel to the surface, and if it goes way down and entraps a lot of fat, the other thing that's really close is something called fibroblastic connective tissue nevus. And fibroblastic connective tissue nevus looks to me pretty similar to dermatomyofibroma, but it does do a lot of fat entrapment at the bottom, and it stains with CD34. And because of the fat trapping in the CD34, there's a potential that you could get it confused with, say, dermatofibrosarcoma protuberans. So I think it's another thing to be aware of, that if you're thinking about dermatomyofibroma. Another thing to keep in your differential is fibroblastic connective tissue nevus, which is nevus not in the sense of melanocytic, but kind of like connective tissue nevus category, where it's a non-melanocytic lesion. Okay, and it's benign. So we've got a tumor in the dermis, extending down into the subcutis. Very plump epithelioid to plump spindle cells, abundant eosinophilic cytoplasm, large atypical nuclei, kind of cleared out open chromatin here. Oh, one thing I was going to point out though is, look at this. So you got these big epithelioid atypical cells, and what are these little cells here?
Neutrophils, yeah.
Neutrophils, look at that. So that is actually a really useful clue for this tumor. When you see these big epithelioid cells with abundant pink cytoplasm and you see scattered neutrophils, right away I think about this tumor. This is a very interesting and unusual tumor for a variety of reasons, but I'll tell you, let me give you some stain results. So, one stain I would want to do, anytime I see an epithelioid atypical tumor, I want to do keratin, right? See, is this a carcinoma, or in this case, this would be, say, from the extremity, maybe from the leg of a 25-year-old patient. So carcinoma, probably not, right? But on the distal extremity of a young person, epithelioid atypical cells, keratin positive, dermal or subcutaneous nodule. So in that setting, you always want to think of epithelioid sarcoma, because they're made of atypical epithelioid cells in the skin or superficial soft tissues, sometimes down near the tendon too, on the distal extremities of young adults or even kids. And this tumor is important because it looks a lot like epithelioid sarcoma, but if we do INI1 or SMARC-B1, which is going to have loss of nuclear staining in epithelioid sarcoma, it's retained here. So these tumors, though, initially were recognized and then they were described because they had a similarity with epithelioid sarcoma. But surprisingly, what happens is if you do CD31 or ERG, these cells are diffusely positive. This is a vascular tumor. Well, where are the vascular channels? It's like solid sheets or fascicles of epithelioid cells. No vessel formation at all. I mean, there's some cracks here. That's artifact on this section. This is not making any vascular channels. And yet, at least what we believe is that this is a vascular neoplasm, one that does not make is not vasoformative, doesn't make vascular channels. So this has been called by two different names. The current name that the WHO uses, and I think it's now become widely accepted, is Pseudomyogenic hemangioendothelioma, because some authors have likened this to having the appearance of a muscular neoplasm or myogenic neoplasm. But the other name that it was given originally was epithelioid sarcoma-like hemangioendothelioma, because of its resemblance to epithelioid sarcoma cytologically, and also the fact that it's keratin positive, which could lead you to make that mistake. And so I think it's really important, even though the name pseudomyogenic hemangioendothelioma is the one that is used currently, I think it is important to remember the similarity that this tumor has to epithelioid sarcoma, okay? And the other thing is that epithelioid sarcomas can also sometimes express ERG, so even though they're not vascular tumors, all right? So So it's good to know about this tumor because it often occurs in the skin or subcutis. The other thing about it is it often arises as presents as multiple nodules in the same like region or extremity, like a patient with 25 nodules in the leg, like the one leg, and they're not only multiple, but they're at all different planes of depth in the tissue. They'll be in the dermis, the subcutis, the muscle, and even down into the bone. So you can have them in the bone and all of the soft tissues and the skin and multiple. So it looks like, like regional metastases. And that's probably what's going on here, is that these tumors have little metastases, but just regionally. And so these are very unusual tumors because of that. So let's see what the most current statistics are, that 60% of patients will experience local recurrences, often multiple local recurrence, or develops additional nodules. And rarely, like 5% or less, they can have regional lymph node metastases. But there have been some distant metastases reported, but it's quite rare. It seems like still very, very uncommon. So relatively unusual entity, and it has a molecular abnormality, serpine FOSB gene fusion. So serpine and FOSB, but they will be positive for keratin, and they will be positive about half the time for CD31, and they will be positive for diffusely for ERG, and then also nuclear FOSB you can do that stain also. And they tend to have the scattered neutrophils present. So it's a weird tumor for a variety of reasons and an easy pitfall. So the neutrophils can be a helpful clue there. All right, pseudomyogenic hemangioendothelioma. And this is a large plaque on the thigh of a young child.
Is that a Kaposiform hemangioendothelioma?
Very good. Yes. Kaposiform hemangioendothelioma, or tufted angioma, if you like. Those names, I think, are currently accepted as being very closely related entities that exist on a spectrum. People tend to, I think, use the Kaposiform hemangioendothelioma term more for the larger lesions, or when they get deeper down and more in larger mass or invasive into the deep soft tissue. And when they're small and limited to the skin, people tend to use tufted angioma. But they really, I believe, they represent the same entity, and we're just applying different names to them kind of based on the size and depth of the lesion. The important thing is that when they're really large masses in young babies, particularly, they have a tendency to entrap platelets, right? And you can get Kaposi syndrome, and that is actually problematic. And when these tumors actually have a relatively good prognosis, but a small subset of patients can die from them. And usually when they die, it's not from aggressive growth of the tumor or metastases. It's from Kaposi syndrome, actually, from having no platelets and bleeding from that. So when they're smaller lesions or not in babies, they tend to not have that problem, and then the prognosis is better there. So the microscopic features that we're looking for, though, are these little cannonballs, right? These little nodules of spindled to oval endothelial cells with little vascular spaces, and they're making these little whorled nodules in the dermis or subcutis. And it's in these little vascular spaces when the platelet trapping happens. It's the platelets get trapped up in these little tiny slit-like vascular channels. And the Kaposiform name comes from the fact that, you know, the little spindled endothelial cells and slit-like channels, kind of similar to what Kaposi looks like. Now, I've never seen Kaposi grow with an actual, like, cannonball pattern. So really, when you've looked at a lot of cases of Kaposi, this looks pretty different from it. But there are similarities in the fact that you've got those little slit-like spaces and the endothelial cells like that. And then the other thing that you have, let's see if it's present in this case. Yeah. In addition to those, you tend to get these dilated lymphatic channels, these big dilated ectatic branching lymphatic channels that kind of run in the soft tissue in the background. Okay, so the combination of those features, the whorled cannonball nodules and the dilated lymphatic type channels, can be helpful to support the diagnosis of Kaposiform hemangioendothelioma or tufted angioma, that spectrum. And I think the WHO actually has them currently listed as, let me double check it before I tell you wrong. Yeah, on the same page, tufted angioma and Kaposiform hemangioendothelioma, and that tufted angioma is what we use when it's a more superficial lesion, and it's otherwise essentially identical to Kaposiform hemangioendothelioma. So really, I think, again, on a spectrum. I think I have one other example. Let me see. Yeah, here's another one. That's a really good one too, see? Got those nice little cannonballs. And then the dilated lymphatic channels. Perfect. And this, I think, was the whole lesion. So here, I think people would usually use the tufted angioma term for this little small one. And you could debate in that other case that I showed, even though it was large, it seemed that it was relatively superficial. So some people might think of it as more tufted angioma than Kaposiform HE. I usually just mention that those two names are closely related and on a spectrum. Now, areas like that actually does look more like Kaposi, although in a young kid you would not be expecting to see Kaposi, but seeing the little slit-like channels going in between the eccrine coils, that's actually a very typical feature of Kaposi. Although when I see that in real Kaposi sarcoma, they actually are kind of infiltrating between the actual individual tubes of the eccrine coil and really destroying the eccrine coil in the process usually.
Could that be nodular Kaposis?
Yeah, good. This is indeed the tumor stage or nodule stage of Kaposis. Very good. And it's very cellular. It makes cellular fascicles once it gets into the nodule stage. And it has kind of atypical cells, but they're not usually like nasty pleomorphic, right? They're enlarged. They have mitotic activity that's usually pretty easy to find. Like, see right here, we got a couple mitoses. But usually they're not dramatically pleomorphic. I mean, it's been reported, and I think that it's supposedly in the setting of AIDS, they can get to be pretty ugly and pleomorphic. But I have to say that I've not seen much real, very prominent pleomorphism in the cases of Kaposis that I've encountered. So usually if I see something I think is a spindle vascular tumor that looks like Kaposi but has dramatic pleomorphism, I'm going to get really concerned for a spindle cell angiosarcoma in that setting. And then, of course, HHV8 can solve that problem for you. So the other thing is that occasionally they don't have good blood-filled spaces. And so when you get the nodule form, and that's what I was looking for, but I could not find, if you have a nodule that doesn't have blood in it, those can be really hard to recognize. And I saw one like that in training where I really scratched my head and I was like, it's this vesicular atypical thing, but not real pleomorphic, and it has mitoses, but there was no blood in it. And it was only after a while we realized, oh, this is actually a Kaposi sarcoma. So the blood-filled slit-like spaces here, when you cut the fascicles in longitudinal section, they are slit-like. When you cut them in cross-section, they look more kind of like a sieve, like little holes, like here. See, the nuclei look more round because we're cutting across the fascicle, and so you have like little tiny holes that are filled with blood, like a sieve or a colander, like a spaghetti strainer, right? You never think of spaghetti strainers the same again. So that was a little thing Mark Edgar taught me, that it looks sieve-like in cross-section and slit-like in longitudinal section. Very helpful clue. And sometimes you'll find more of the earlier stage pattern of Kaposi around it, but other times you'll just see the nodule. And then up here, I think, we have some dilated vessels. Some of these may be background lymphedema. You often, particularly I think in older, the classic form of Kaposi, where you get one or multiple nodules on the foot or lower leg of an older person, you often have background lymphedema, chronic lymphedema, like changes in the background in addition to the Kaposi sarcoma. And I don't know exactly why. I don't know if it's that the Kaposi causes lymphedema or that the people get lymphedema for some other reason, and the lymphedema creates a kind of zone of kind of immune suppressed zone because the lymph is not draining correctly. So, lymphatics play an important role in immune response. And then maybe that's what allows the HHV8 to start kind of growing out of control. I'm not really sure, but I've definitely seen some cases where there was abundant lymphedema in addition to the Kaposi. So sometimes you can see the promontory sign like we've got right here, right? Promontory sign everyone loves to talk about, but I would say only a minority of cases that I've seen of Kaposi have really good, like classic promontory sign. So it's kind of a vessel gets pushed out and surrounded by, it's kind of a mound of Kaposi here pushing into the space, and there's vessel around the outside. There's also a vessel in the middle here too. Here's another one. Here's a vessel, and it's kind of floating inside another vessel space. So it's kind of nice when you see it, but you certainly don't need it to make the diagnosis. And you often have a lot of plasma cells around Kaposi. I would say the majority of cases of Kaposi I've seen have plasma cells in the background, so it's a useful clue. Oh, and there was one other thing I was going to show. It was over here, I think. See if I can find it again. Yep, there we go. Little eosinophilic globular inclusions. So I've learned different things. There's more of them up here. Some people have told me that these are ingested red blood cell fragments inside the tumor cells. I don't know. I've not investigated the original literature to see where that idea came from. Maybe someone did electron microscopy and proved that or something. I don't know. But to me, I've seen other little eosinophilic hyalinized droplets in many different types of tumors, mostly sarcomas. But so I don't know that, to me, they don't stand out as a real specific thing because I see them in a variety of sarcomas kind of non-specifically on a regular basis. But they are a feature that's been reported as a common finding in Kaposi, and whether they actually represent red blood cell fragments or whether they represent droplets of proteinaceous material, I don't know, but they're there. And one of my fellows, Betsy Uhlenhake, she was the one who told me that these have been referred to as dwarf balls. And it's the most obscure piece of knowledge, but I did go look and find some reference where someone referred to these as dwarf balls, D-O-R-F balls. So I don't know. Try that out at your next cocktail party and see what your friends think. But that was news to me, but Betsy taught me that. And sure enough, it was out there floating around in PubMed somewhere. So in any case, nodular Kaposi sarcoma. All right, guys, I think that probably should do it for the day. And for everyone at home, thanks for watching. Hope you enjoyed.